Okay, so you have the anatomical neck, not to be confused with the surgical neck, which is found around the shaft of the humerus. Yes?
Yes.
Okay, and then you have two bony projections around the shoulder. They're called tubercles or tuberosities. And what is the purpose of a tubercle or tuberosity?
Connection of tendons and ligaments.
Okay, so that's for attachments of tendons and muscles, right, and ligaments. So they're going to have a rough surface. The one that's going to be most lateral and superior, Maureen, okay, is which tubercle?
The greater.
Okay, and then the one that's going to be more inferior,
Lesser.
and medial is going to be lesser. Now, what's that area between the two tubercles or tuberosities?
Bicipital groove. Bicipital groove.
There you go. Bicipital groove, or the intertrabecular groove. All right. So right below that then is the part of the shaft known as the. Right below that. What is that? It's another name. It's another type of neck, right? It's a surgical neck, and why is it called a surgical neck?
That's the most common break.
The most common place for a break, okay? All right, and then we have also the deltoid tuberosity. So what do you think attaches there?
Deltoid for your shoulder.
All right, almost done here, guys. Jason. Maureen, again, where's Maureen? Okay. Paris.
You finish it, Evan?
Yeah. I turned it over here.
Did you?
Yeah.
Oh, I thought you said you were gonna finish it.
I did.
You made it nice and pretty.
Real cute.
All right. Okay, so here we have a radiograph of an Ap humerus. What are the bony parts or landmarks that we're going to be feeling for to get the humerus into a true AP?
Epicondyles?
Epicondyles, okay? So what do we have to do with the epicondyles, guys?
Make sure they're parallel.
Okay, parallel to what?
The IR.
Get the image receptor, okay? So when we get an AP humerus, now we're looking at the most proximal part of the humerus is the shoulder. In the true AP, what's going to be demonstrated here, obviously, is going to be the greater tubercle, which is right here on the side, because we said the greater tubercle is going to be lateral and most superior, right? So that would be B. The other tubercle then will be projected in the head of the shoulder. That will be the lesser tubercle. And then you can see the space in between is going to be the intertrabecular or the bicipital groove. Okay? And this, again, this is how we know it's in a true AP by palpating the elbow and placing it parallel with the image receptor. All right, so today's discussion of the shoulder girdle,
Girdle.
thank you, is going to consist of the scapula and the clavicle. Okay? All right. The clavicle, there it is. There's not a lot of parts to it. Okay? You've got the shaft and you've got two ends. One end articulates with the acromion of the scapula. Okay? This is going to be the acromial end, and this area here is the acromioclavicular joint, also known as what?
AC joint.
The AC joint. Okay, AC for short. At the other end of the clavicle is the sternal end, and articulates with the sternum or the breastbone. And what is that called? What is the joint there called?
Sternoclavicular.
Or
SC.
SC joint. Okay, sternoclavicular or the SC joint. Okay, and that's it. That's all they talk about the clavicle. What's another name for the clavicle?
Collarbone.
The collarbone. Okay. So the clavicle is what communicates the scapula with the sternum. Okay? The clavicle is what communicates, is the communication between the scapula and the sternum. We'll cover the sternum in another presentation. So our focus is going to be on the clavicle and the scapula today. Okay. All right. So let's see. Let's see. Okay. Well, what part of the clavicle?
The shaft.
The shaft of the clavicle. What end is B? Sternal end. And what end is D?
Acromion.
What is the joint in E?
AC joint.
AC joint. And what is the joint in A?
SC.
Okay. All right, we're done. We're done. So let's do the scapula. Okay. The scapula is a little bit more complex. Okay. The scapula is, the other name for the scapula is the shoulder blade. It has a triangular shape. It has 3 borders. Okay. Very simple borders. The very top is the superior border. Then we have 2 sides to it. So you have a top and 2 sides. The one that is medial is the medial border, but it's also related to its proximity to the vertebral column. So that would be called now what? The vertebral border. Okay? Then you have the most lateral, so it would be called what?
Lateral.
The lateral border. And because of its relationship to the armpit, or the axillary, it's called the axillary border. All right? The relationship between the humeral head and the glenoid fossa that we'll talk about here in a moment, the glenoid fossa of the scapula, is known as the scapulohumeral joint, also known as the glenohumeral joint. So those terms are used interchangeably. Most commonly it's called the scapulohumeral joint. All right? So here we have the anterior view of the scapula. We've already covered the borders. It also has 2 angles, 2 points. The first one here is the superior angle, and then we have the inferior angle. The majority part of the scapula is known as the body, also known as the blade, also known as the wing, also known as the ala. Okay? They're all used interchangeably, so depending on who's talking about it or what literature you're reading, all these terms are analogous. Okay? Just like many of the bones that we've been studying so far, the scapula also has a head. Okay? We talked about the superior angle, we talked about the inferior angle, but it also has a lateral angle, lateral being towards the vertebrae or towards the armpit?
Armpit.
Okay, towards the armpit or the axillary, okay? So it has a lateral angle. So right below the glenoid cavity or the glenoid fossa is where you're going to find the head. So it's right off the fossa. Extending from that is the neck. Okay? Now, the 2 palpable landmarks that you are going to be getting yourself familiar with when we're x-raying the scapula are the 2 bony projections. The first one here is the Acromion process. The Acromion process is going to be superior and more lateral than the Coracoid process. The Coracoid process is going to be anterior, medial, and inferior to the acromion. The acromion is going to be posterior of the 2. Okay, so the acromion is posterior, the coracoid is going to be anterior. Now we all know where the acromion is, right? Can you find your acromion? Just follow your clavicle until it ends. That bony projection at the very top, that's your acromion. All right? Now the coracoid is a little bit more harder to find. And to find that, you have to go slightly in about ½ an inch from the acromion, so you can go medially about ½ an inch. And right below your clavicle, there's that bony projection right below your clavicle. Okay, I'm gonna have to fill you out later on. Okay? Private party. Okay, but I'll show you exactly where that is. It's very tender to the touch, so when you press on, it's kind of like the Spock death grip. When you grab on that, they do this.
Yeah.
And it
Right
hurts.
there.
It's very tender, okay? So we'll practice how to find that particular landmark in the lab. All right. What else do we need to talk about here? Okay, so right off the coracoid process is a dip, and that's called the scapular notch. What else? Okay. Oh, okay. The front surface is the costal surface, and then also the back side is going to have the posterior surface that we'll talk about here in just a little bit. Okay. Any questions on this particular slide? All right, here's the posterior. Now, remember the acromion. The acromion is that superior process that projects right off your clavicle, right? The acromion process. Now, from the acromion, it continues across the scapula and has a raised edge to it, and this is known as the crest of the spine, okay? It is an extension. You guys got to write that somewhere. The crest is the extension of the acromion located posteriorly. The crest of the spine is the extension of the acromion located posteriorly. Off the spine, we have two areas, above and below. There are smooth indentations or depressed surfaces. On the top of the crest is this depressed smooth surface here, and that's the supra meaning okay, above, supraspinous fossa. And right below that is going to be the infraspinous fossa. Okay. And then the posterior surface of the scapula is known as the dorsal or the posterior surface. All right, any questions so far? Now, the scapula is a very tough bone to break. Okay, so if you have a patient presenting in your department and you shoot some x-rays of the scapula and it is broken, they've likely received major trauma. Okay, in my life I've been taking x-rays. I've done many scapulas, but only run into one fracture. Okay, I'm talking about the blade. You can break your acromion. This can snap. Okay, these are easy to snap, but I'm talking about the blade itself is very difficult to break. So this guy came in because he got assaulted with a bat. Yeah. So someone took a bat and swung on his backside and cracked his scapula in 3 different places. Huh?
Can we feel it?
Can we feel the crest? No. Yeah, it's just kind of tough because you have so much muscle here in the back. It's sometimes hard to feel that crest. Yeah. Now, unless you're, a little bit more slimmer, yeah, you can feel it. But on someone like me,
No way.
no, it's hard. It's hard to feel it. There's a lot of muscle back there. Yeah. All right. Any questions here, guys? All right. So now we have here a lateral scapula. It takes the form of a Y. So when you look at that scapula sideways, it takes the form of a Y. So this particular view is known as the scapular Y view. Okay? The Y is formed by the edges of the blade, and then you have your acromion and your coracoid process. Now the coracoid process, this sounds very similar to, yeah, it sounds like coronoid process. So how can we tell the difference?
With A on top.
Okay. Well, the way I remember it, coracoid, scapula. I know it doesn't. because of the sharp C, coracoid and scapula is how I relate it. Okay.
We're like, and?
Yeah. Well, you guys can make up your own analogy later on. But that's how I remember it. Okay. So coracoid associated with the scapula. All right. So remember the relationship of the acromion and the coracoid. Okay. So when you're looking at it laterally, B is going to be more superior So that would be which of the two?
Acromion.
Acromion, and A is more inferior, so this would be
Coracoid.
coracoid. Again, acromion is posterior, so this is the posterior part of it. And anteriorly, you have the coracoid. Okay? So if you remember those relationships, you should have no problem in identifying these different structures. Okay? All right, let's keep on going. So here we have the AP scapula. The AP scapula. It is done in this particular manner because when your arm is in rest, it places the scapula right in the middle of the lung field. Okay? Now what's the problem with that? Why is that an issue? Well, what's in the lung field?
Air.
Air. Air is highly penetrating. So if you were to shoot this x-ray with the arm in neutral position and the scapula is in the lung field, it'll get burnt out. You can't see it. What I mean burnt out is you're going to have increased density because you're looking at lung and not bone. So it's very, very hard to see. So what they do here is they have the arm extend out to pull the scapula laterally. It doesn't completely leave the lung field, okay, but it gets most of it out of the lung field so you get better visualization of it in an AP projection. Okay?
Wait, so you're saying if something is less dense, it's harder to penetrate?
No, I'm not saying this. Yeah, something that's less dense like your lung, x-rays go right through it and interacts with the image receptor, increasing the density of your image. So even with the scapula in the lung field, because it's highly penetrating the lung field, your image in this area is going to look particularly dark, which makes it difficult to see the outline of the scapula. So we raise the arm up to project the scapula more laterally for better visualization. Does that make better sense now? Okay. And we'll talk about this particular position here in just a moment. Okay, so what do we have here for D? Let's start with D.
The sternal
Okay,
end.
so that's the body or the shaft of the clavicle. What is C? That's the joint.
The
The AC joint.
Okay. Now what B is pointing to is this thick area going across the top of the scapula. It's going to be the crest or the spine. Okay, so this is the crest or the spine of the scapula. What is this joint called over here?
The glenohumeral.
Okay, so we have the glenohumeral or
The
the
scapulohumeral.
scapulohumeral joint. Okay, and then G is pointing to the border.
The lateral border.
Lateral border or the axillary border, and then this border in relationship to the vertebrae. So this is the vertebral or medial border, and then this angle down here,
The inferior end.
inferior angle. Okie dokes? What's A? I think it's pointing to the AC joint. Well, what did I say C was?
C is
Oh, C is the, I think it's pointing to the notch. Okay, A is going to be the AC joint. What do you guys have there in your book? Oh, you guys don't bring your books, okay. What is that? Let's see. You haven't opened your book yet? Yeah, I think this is the extension of the acromion, so this is the AC joint. C, I'm not quite sure what it's pointing at. I'm going to say it's probably the coracoid process, because this is the coracoid process right here. Yes? No?
They're looking.
And I don't bring my book. I got too much stuff in my box already. Does it say?
Spine of the scapula,
The spine? So then what's B?
the glenoid cavity.
Then what's H?
Which one?
H.
The head? No.
That can't be right.
the right one, I'm sorry.
Okay.
So, C is suprascapular notch.
Okay, so that is the notch, okay.
A is acromion.
Acromion, B is the spine,
H is glenoid cavity.
cavity, and B is the spine. Okay, so that is the, oh, so that's the notch, not the, not the coracoid, okay.
What was C?
Okay, so let's do this again. So A is the AC joint, B is the spine, C is the notch, D is the clavicle, H is the fossa, and then we already covered G, F, and E. G is the lateral border, E is the medial border, and F is the inferior angle. The
glenoid fossa.
Glenoid fossa.
What
Also
page is
known
that
as
on?
cavity.
181.
Okay. All right. Here's your scapular Y. Again, based on what we know of the location and orientation of the two projections. B, what?
That last X-ray.
I'm sorry, yes.
The last one, we're not gonna have something like that on the test, are we?
Well, you I don't know, maybe, but the labeling and the lines will be a lot more clearer.
Okay.
Yeah. Sorry, I didn't mean to answer you what. Like I was irritated. All right, so you have two body projection. You have the anterior, you have the posterior. So most superior is going to be what?
The Acromion.
Acromion process, and you can kind of see the clavicle extending to the acromion process, and this would be your AC joint. Okay? And then the anterior and lower one is going to be
Coracoid process.
Coracoid process. The lateral, this is a very difficult, projection view to acquire because of the body habitus. The position of your scapula changes with the habitus of the individual. So you're thinking your scapula should be plain and flat on your back, right? So the larger you are, the more angled your scapula is. The more smaller you are in body habitus, the more straight and flat the scapula becomes. So when you're trying to rotate your patient to get the scapula in a true lateral projection, like she is right here, the rotation depends on the body habitus. And depending on which book you are reading to, there's a great difference. I think it's anywhere between 30 to 60 degrees rotation. That's a huge difference. So how much rotation are you going to use? So I'll show you guys a technique in how to kind of eliminate the exact rotation, but you can figure out the exact rotation by feeling other anatomical structures of the scapula, and I'll show you guys that later on. Okay? But there's a huge difference between the 30 to 60 degree rotation based on body habitus. All right, here's one what we call the infrosuperior projection. This is infrosuperior projection axial. It's an axial projection. You guys remember axial? Okay, so it's infrosuperior axial projection. This is also a common view that we do in the radiology department. This is a little bit more tougher to do, so I'll show you optional views. Okay, but here you have the patient lying on their back. You prop them up, the shoulder has to be propped up, and the cassette has to be placed by their neck. And not only is it difficult, but can also be very painful because you're pressing the edge of the cassette on their neck to try to get the head of the humerus in view. Okay? Now in this particular view, you will see the acromion process projected through the humeral head. Okay? So this is the outline of the acromion process being projected through the humeral head. So here's the head. Here is the glenoid cavity or fossa. Anteriorly, right? So this is anteriorly, which process is this?
Coracoid.
This is your coracoid process. Posteriorly, this is the acromion. So acromion, coracoid, all right? And then the extension of the acromion is this very dense edge here. What is that called? It's the crest. It's the crest.
So C is a crest.
C is the crest. That I know for sure. You don't have to look that up, okay? Also, what's demonstrated in this particular view and projection is the lesser tuberosity of the humerus, okay? Which is this area right here, the lesser tuberosity. All right? So do we need to go over that again? A is the coracoid.
D is actually the acromion. They're pointing to the superimposition behind
Isn't that what I said?
the.
Yeah.
Yeah, so D is the acromion.
Sorry.
Okay.
You're not.
Okay. Okay,
Moving on.
so yeah, that's okay. So A is the coracoid. D is the acromion projected through the head. B is the glenoid cavity. Okay, or pointing to the scapular humeral joint. And then C is the crest. Yes.
So, on the humerus, the lesser tuberosity isn't anterior on where the B line is, but it's
Not
on
in this
top?
particular projection. So it's going to be the greater is going to be this right here,
Oh, wow.
right here, and the lesser is going to be up here in this particular projection. Because now we're not looking at it like this. We're looking at it like this. So the lesser is located
Oh.
here. So when it goes up this way, it now gets projected superiorly. Yeah, you're just changing your point of view. Okay. All right. All right, we already covered this, and then we keep on moving. Synovial. Okay, so the shoulder joint then is a ball and socket type of joint. Okay, it's diarthrodial, meaning that it's freely movable, and it's encapsulated in a synovial capsule. Okay. So your shoulder joint or your scapulohumeral joint, again, is spheroidal or ball and socket. Your SC and your AC joints are plane or gliding.
I know for the quizzes, it's normally just positioning for the
Mhm.
exam. We need to know the joints or the.
I think I'm going to be breaking it out to two different parts. I think one is positioning and the other one will be anatomy. Yeah. Yeah, so in other words, you need to know everything.